Good morning, everyone, and welcome to our Behavioral Health Learning Event session. My name is Courtney Wheeler, and I am a Public Health Manager here at the National Indian Health Board, and I'm going to be moderating today's session. Today, we're grateful to have Dr. Lori Rainey here to present on the importance of behavioral health during and following the pandemic. There's a few housekeeping things I want to go over before we get started with our presentation. Just so everyone is aware, this session is being recorded. All participants have currently been muted during the presentation, so please leave yourself on mute unless the presenter specifically asks you to unmute and engage. After the session, you will need to sign out in order to get your CE credits. Once you sign out, you'll be taken to a link to complete the evaluation. I also want to remind everyone, you can please type your questions and comments in the chat box here in the Zoom room. I will be monitoring that chat box as well as Dr. Rainey, and we will get to your questions as soon as we can. There will be a time for Q&A at the end of her presentation. However, she may choose to respond to questions throughout. So now we will begin. I will turn it over to Dr. Rainey. Thank you.
Thank you so much, Courtney, and good morning, everyone. Really pleased to be here with you this morning, talking about a subject that's near and dear to my heart. I am actually a psychiatrist and have worked with the Indian Health Service and with tribal communities for the past 25 years, first on Navajo, and now I'm a staff psychiatrist with the Ute Mountain Ute Nation in Toyoak, Colorado. And really have seen firsthand what's going on in terms of behavioral health in Indian country. And I want to talk today not only about COVID and what's happened, but also to really start thinking about solutions and what are some things we can do? What are some things that have actually already happened? I want to share a project that I've been involved with the Indian Health Service. That's a grant-funded project. And I really also want to hear from you. We're going to talk about really how to extend access to behavioral health, because COVID has really, let us know not only was the problem, we had problems with access before COVID, but we certainly have new problems now because of what's happened during a year and a half of lockdown and grief and losses and those sorts of things. So in the chat box, as we go through, I really would love to hear from you guys, and also for you to share with your colleagues what innovations, what have you done new and different during COVID, before COVID, to really address the behavioral health issues that are going on right now. Today, what we want to do is we want to really talk about, again, what are those benefits of integrated care, how that might actually help expand access to behavioral health. We're going to talk a lot about providing behavioral health in places other than directly in our behavioral health clinics, which tend to be overwhelmed. We're going to talk about other team members who can help in addition to behavioral health, licensed or trained individuals. Really talk about what a continuum of care would look like that goes all the way to self-care in the community with culture and management of symptoms, all the way to inpatient psychiatric hospital would be the other end of the spectrum. So really trying to think about how we can develop more of a continuum and not have just a behavioral health system sitting out there by itself. And we're going to talk about using measurement. How do we kind of think about symptom measurement so that we can actually do a better job of providing behavioral health care? I want to share with you this is an Indian Health Service funded 4-year grant that I've been involved as a consultant with over that time. 12 tribal clinics applied for these grants back 4 or 5 years ago at this point. And for the last 4 years, we've really been helping them try to figure out how to increase access to behavioral health in their settings. And this was a pilot project. And if it was successful, then the Indian Health Service was moving to fund 15 more sites. So you'll see at the top right, this is actually something that has been approved. The RFP is not out yet, but for those of you who might be interested in signing up for the next round of funding, keep an eye on the Indian Health Service grant funding website and where those resources are kept, because we're really hoping 15 more sites for 5 years. This time it's going to be a really long grant to really help people, clinics, increase access to behavioral health again, through an integrated care project where we're really moving some of that care to primary care, which I'm going to show you a little bit about that in a minute. From Alaska all the way across the West, we've really had quite a few clinics apply, and it's just been really exciting to watch their progress. We've learned a lot from what they've done. I'm going to share a little bit of that with you today. And so for the next round of funding, we'll be really ready for implementation and to help people get started up and running pretty quickly, which is really going to be necessary with what we've seen with COVID. Mental illness and substance use disorders among American Indians and Alaskan Natives. This is adult information only. As many of you know, there are individuals that really struggle with substance use conditions. There are individuals who are struggling with a mental health condition. And then there's a population of people that actually have both. So we have our work cut out for us in terms of designing a good system within Indian Health Service and in tribally run clinics to really try to address this issue. And these numbers have actually gone up in the time of COVID. And part of it has been really, as you guys know, American Indian and Alaskan Native populations have really had a disproportionate share of COVID. The Ute Mountain Ute tribe I work with here has really struggled. The Navajo Nation, some of you I think are from there. I can see some of you in the participation list, nice photos that look like they're from Window Rock and other places on the reservations. But the Navajos really struggle with a lot of loss. Infection rates have been really high. Again, there's multi-generation households, all kinds of reasons that this has gone on. Working on Navajo, really realize just issues like, hauling water out to your house can really affect whether or not how much infection control you can do, more likely to be hospitalized, and higher rates of mortality, which have really, brought a lot of grief to tribal communities. So with this happening, we already had the issues that I showed you on the previous slide. Now we have this compounding of, what's really needed in terms of services for our tribal members. So let's just talk about behavioral health in general. Across the population, if you have 10 people that have a diagnosable behavioral health condition, 6 of them are getting absolutely no treatment. So 60% of people with a diagnosable condition are not getting any treatment for lots of reasons. There could be lack of access to that care. There could be lack of funding for that care. There could be stigma about that care that keeps the person from getting it. There could be family members. The stigma can be with the person, but also with the family who encourage the person not to go and seek behavioral health treatment. Of those that are getting treatment, about half of them are actually getting treated in primary care. They're not actually getting treated in the specialty behavioral health care. Their PCP, their primary care provider, is actually providing either medications or counseling or those kinds of things for those patients. And then about 2 or 20% are actually seeing a behavioral health person. So we have a big problem in terms of access to care and addressing stigma. As many of you know, stigma around behavioral health conditions can sometimes be more in tribal nations. I was at a clinic a couple of years ago, and they called the trip over to the behavioral health clinic. It was actually called the Walk of Shame in the community. I also worked in the clinic that I worked in. Behavioral health was in a trailer in the back, and there was a lot of concern about people seeing you walk into that trailer. So I really do understand concerns and issues around stigma. So again, we have our work cut out for us in our communities in terms of just thinking about, what we can do to actually help people move beyond that barrier and receive care. Now, if we don't have the resources, we are going to have people without care. So we have to make sure we increase that access also. So how do we think about, bringing in care from other parts of the clinic? How do we think about actually identifying people? And if you think about it, actually what shows up in primary care, you can have a 67-year-old man who was recently widowed, or a young person with a stomach ache, or someone who's just drinking more than usual, someone with diabetes that's uncontrolled. Someone may walk in and say, I can't get out of bed in the morning, and in primary care, they're worried about a thyroid condition or something else. But when we actually take a look and we screen folks, what we actually find is that there can be some behavioral health actually diagnoses that are driving. So that stomach ache turns out to be an anxiety disorder. Whenever the young man has to stand up and give a presentation or speak in front of people, he gets so anxious, his stomach is upset. The gentleman who's been recently widowed may be having grief, and we can help him with some brief interventions in that primary care setting. Again, there are things we can do to really begin to address some of the problems. The person with diabetes, they may not have a behavioral health condition, but they may need some behavioral health intervention around trying to stick to their treatment regimen in order to be safe and healthy. When we think about where then the behavioral health treatment can lie, it's everything, like I mentioned before, from self-management in the community, and much of that can involve family and cultural practices, but other things too. A lot of self-help apps and things that folks are using, all the way up to what is it we can provide in primary care, which is what this IHS grant that I mentioned earlier, that's what we were trying to sort out in that pilot, to behavioral health. So what does it look like in your behavioral health clinics in terms of therapies? Do you have access to psychiatrists? What does that look like? And then what is it like if someone needs more intensive treatment, like an assertive community therapy, assertive community or ACT team for people with serious mental illness or inpatient psychiatric hospitalization? I know when I worked on Navajo, it was a 5-hour drive to the nearest inpatient unit. So we really want to think about a continuum, and not everyone needs to just go to behavioral health. So when we go upstream to primary care, we're not asking primary care to treat the most severe people with the most severe illness. We're really asking them to deal with some less complex common conditions in that setting, so that we can free up the tip of this triangle for our behavioral health folks who have the most extensive training in treating mental health conditions. So right now, almost everybody goes to specialty behavioral health. And what we really want to start thinking about is, how do we move some of that treatment back? And I'd be really interested in the chat box. We have about 25 people on the call today. How many of you are actively already trying to place some of that treatment in primary care and do some of the things that we showed in that IHS grant, where we have those 12 clinics? So if people would just take a moment and in the chat box, let your colleagues know. And if you're not doing anything yet, is there something that you and your clinic or your community is thinking about doing? Because I'd be really curious how many of you may already be doing this and may have some things to share with folks on the phone today. So what is that role of primary care? This is actually assigned in a clinic in South Dakota. Behavioral health and medical patients, they're all in the same waiting room together. Who knows where they're going? You don't have that stigma of being over, or feeling like it's over in the behavioral health clinic per se. But in primary care, they're really able to detect symptoms on the front line. Depression screening in primary care is actually a performance metric for all tribal and Indian Health Service clinics. So we can begin to pick up and screen, and then figure out where the person needs to be treated. It's really important. I've got the word screen on here 3 times intentionally. It's really important that we're screening for substance use, screening for anxiety, screening for trauma, for childhood and adult disorders and condition. And then in primary care, you can really have folks step in and actually help the PCP, help the primary care provider, by having social workers and other people really in that primary clinic helping them. It's going to take some changes in workflow across the 4 years of the grant. Our clinics really struggled initially with, how do I change up that workflow for primary care? And then we need to really think about, when we do refer people, let's make sure they go. I don't know about you guys, but for me, the no-show rate for first visits with a psychiatrist in my clinics is about 50 to 60%. And that means we haven't really gotten, into really engaging patients if that many folks are no-showing. So we need to kind of figure out what that looks like. If we want the integration to work well, we need to think about, what are those principles? What are those primary things we need to be looking at? And I'm looking at the chat box and I'm not seeing any comments in there. So I'm wondering if none of you are doing any integration yet. I think it'll be really helpful then as we go through this to give you a sense of what that might look like. And again, really encourage you to apply for that grant when it comes around. For integration to be effective, we need to develop a team. So again, we're going to have a team that's going to come in and help primary care. We're going to do evidence-based treatments. We want to make sure that what we're providing works. We're going to measure that care over time. I'm going to show you how we do that. And then it's a population-based strategy where we want to make sure everyone's getting better, no one falls through the cracks, and that we're really tracking and following what we're doing, which is what all of our grantees had to do this past year. This is kind of what it might look like. So we have a patient, we have the gal in the red sweater is in that clinic helping that primary care provider. The patient's right back here. So the gal in the sweater is doing this dance where she is literally in the primary care clinic and helping out. And if this is effective and it's working, we don't need to refer that patient to the behavioral health department. We actually would be able to provide some of that care. We just have something in the chat box where someone is working for a fairly qualified health center and is really looking at the integration approach. So that's really good to hear someone out there is actively already doing that. And then what we're doing behind the scenes is we're measuring their symptoms. You can have psychiatric consultation. Here's me with my phone, ready and willing to talk to primary care providers if they have questions. And we also are really looking at, it's not just primary care and behavioral health, but also what are any of the traditional or cultural healing practices that might be helpful. And all of our clinics, as we went through this grant, really worked on kind of three-way integration: primary care, behavioral health, cultural, to see if we can, again, expand access to behavioral health care. So what does that look like when we screen? Well, what you'll see is that a lot of your clinics are using validated tools. In a lot of clinics, you guys may be asking the PHQ-2, which is 2 questions about depression, but there are many, many tools that you can use to help you find those patients that have a behavioral health condition. And again, they may be coming in, as we saw in that earlier slide, coming in with a stomach ache, and it turns out they actually have anxiety. So this tool called the GAD-7, it's the Generalized Anxiety Disorder 7-item tool, can actually help us pick up that young man. We might have given him a workup for stomach ache and done all kinds of other tests, but if we give the GAD-7, it may turn out his score is really high. Okay, so these are the kinds of screenings that are going on in a primary care setting. Some clinics do more than others. Some may just do the PHQ-2. Some of you may be doing a variety of different tools, and I'd be curious if any of you are using screening tools, to put this in the chat box. And then we also have tools for children. We have tools for trauma. We have all kinds of, these are what I put in here today are the most commonly used tools. So I'd be curious among the audience today, are any of you, I'm guessing you're all using the PHQ-2, but are there other tools that you're using to screen your patients as they come in, so that you're catching this either undiagnosed behavioral health that may be masquerading as something else in the primary care clinic? Here's just an example of a PHQ-9. Here's some, I'm just looking in the chat box, the PHQ-2, the GAD-7, here's quite a few things that folks are doing in terms of helping and managing visits. That's really just cool to hear, Sherry, what you're doing in your practice, because you really do want to catch people coming in the door who, again, people come in for a well child visit, adolescent come in for a well child visit. If you screen them, you can find out they have depression, and they may even be suicidal. So it's really super important that you do this. This is what the PHQ-9 or the patient health questionnaire looks like, 9 symptoms of depression, and it asks a question about whether or not you're feeling suicidal. We look at that total score. If it's 10 or above, we move on to try to think about, what are we going to do about this? And it gives us something to really act on. In terms of thinking about that. I'm also seeing from Frankie that they're using the CRAFT, and the CRAFT is an important tool for substance use for adolescents in particular. And I always forget what it stands for. I know the first is car and friends, and it goes on, but it's really asking adolescents specific questions about where they may be around someone who's using a substance. So that's what the tool looks like. And what we're looking for to happen is for people to either get better, or if they're not getting better, let's take these tools, let's figure out if we need to bump up the treatment. Remember that continuum of care we were showing earlier. This patient up in the left came in 8 weeks ago, got some care. That could be brief therapy, that could be medication, that could be helping address their social determinants of health, whatever that looks like. And over the course of 8 weeks, nice drop in scores, reached remission, perfect. The person at the bottom is struggling. They initially got better around this 36-week mark, but then it's just been really intermittent and up and down. This could be anything: a person with chronic pain, a person with a chronic substance use condition, someone with a personality disorder, someone who's in and out of being homeless. All kinds of things could be happening here. But when we look at this trend over time, we might say about this person, hey, they need something a little different. What we're doing is not working for them at the moment, and really kind of taking a look at that to see what's really happening with them. And I really like, Megan put a comment in here about being in an emergency department. Every patient gets asked 5 questions, regardless of the reason that they came in. I love that, because it's really, we're really trying to get at what are we missing in the system, and then how to refer that patient. So that's a really neat approach to thinking about how to do this work. So we measure, and then if people aren't getting better, we do something about it. We do this in all of medicine. We do it for diabetes care, hypertension care, all sorts of different ways we do this care. And now we're doing it for behavioral health, so we can put the patient in the right level of care, make sure they're getting better, and if they're not, do something about it. So what does this treatment team, what does this kind of look like? So who are these behavioral health providers, behavioral health consultants? You'll hear them called BHPs, BHCs, behavioral care managers. There's lots of different terminology that we use. And this is actually, for those of you who've been in primary care, remember the little flags outside the door? This is actually a little flag that says, hey, the behavioral health consultant is in the room or is needed in the room with the patient. There are all kinds of different people. They can be licensed, they can be unlicensed, and we're really trying to stress to clinics, especially in remote areas, that you're not always going to find a licensed social worker to move to Kodiak, Alaska, or to move to Montana, or some of the more isolated places that we have. Even here where I live in just outside of Toyac, Colorado, sometimes it's really hard to find licensed people. So it's a combination of licensed and unlicensed. Folks who really believe these brief interventions can be helpful in primary care, and who have the skills to listen and see what's going on and be supportive and get people out where they need to be. It's kind of a special hire. It's not like traditional therapy. It's not a fern and a lamp at the end of the hall or across the street. It's really someone in there in the nurse's station, working with people in the exam rooms, really trying to do brief interventions, see what they can do to help the person get better, without necessarily having to refer them if it's not needed. A very different approach to care. And I'm guessing for some of you who may be working in FQHCs or tribal clinics who are doing integration, you're kind of used to this dance, and you're a special kind of person. Not everyone is cut out for this. And you need to be careful putting someone in this clinic who's not comfortable with this kind of work. It's almost like a subspecialty of behavioral health, and it's really expanding across the country. Social work schools, psychology schools, there's all kinds of folks teaching people how to do this. There are training courses that your staff can attend that are like 16 weeks of webinars and training and role plays. So it's really just a fascinating field. And again, we had our grantees this year, and as we can see in our chat box, we actually have people already doing and have been doing integration for a while. Our tribal clinics are, primary or physical health, mental health, vision, and dental. Those are the 4 things we've always provided. Now we're actually going to move some folks around, put some people in different places so that we can capture patients early, do briefer interventions, and not have to get them connected to longer term behavioral health unless they truly need it. The behavioral health providers are doing evidence-based brief interventions, whether it's to help you using motivational interviewing, manage your diabetes or your substance use problem, or doing something like problem-solving therapy or behavioral activation. These are all evidence-based interventions used to really help people get better. So we have to train our staff on brief interventions. Most of them are used to longer-term interpersonal psychotherapy, and we have to actually do these trainings to help people. And you can train a lot of people to do behavioral activation, a nurse, community health representative, a community health worker, a medical assistant. All kinds of folks can do these particular brief interventions. The other thing, and I was mentioning this before, is we need to think a lot more broadly about who's on our behavioral health team. It's not just licensed behavioral health folks, which all the way to the right. So I would call that your behavioral health provider 3. level. License, they can make a diagnosis, they can do all kinds of deal with more complex behavioral health needs. But like a behavioral health provider 1 or 2, and you can have different job descriptions, case managers, care coordinators, all kinds of folks can get, they've got some advanced training, they can really work on expanding your behavioral health workforce. So we really have to get beyond, oh my gosh, we've had a vacancy for a social worker for a year or a psychologist for a year. We need to think about that larger behavioral health workforce. Now, COVID's taught us a lot of things, and one of them has been, and some of this was going on pre-COVID, was the ability to have that behavioral health provider be remote. Where I worked on Navajo, we had our main clinic in Kayenta, and we had a more remote clinic at Inscription House. And to be able to provide that care, it was an hour drive for me out to Inscription House. I go out once a month, I have an hour drive back. But the idea that I can do virtual care and I could be in Kayenta and beam out across to these different clinics would have been very helpful. That was back before we were really getting into this in a more intense way. But you can see here, I have a patient in the exam room talking to a therapist who's in a different clinic. And, we were doing a little bit of this beforehand, but with COVID, we certainly started doing quite a bit. So there was a lot more virtual care going on, individual therapy, group therapy, support groups, traditional medicine approaches. I'm going to show you towards the end, just a number of things. People got so creative around virtual care, and we dispelled some myths that we can't do this way. We really had people engaging. Our behavioral health providers couldn't come into the primary care clinics. Many of our primary care providers were working remotely. So we had both the behavioral health person remote, and we had the primary care provider either calling or video conferencing the patient. We know there's some limitations in terms of some of the technology and reaching people in remote areas. I have patients that don't even have cell phone service, or sometimes don't even have a cell phone. So we know there's some barriers, but we really learned in this process, because all 12 of our grantees, this was not expected, had to move virtual very fast. And so we actually had a chance to actually look at that during the course of the grant. And here's some just photos from some of the things that folks were doing in terms of working in order to really be able to keep services going, even when COVID hit. This is Dr. Jen Edwards. She's a primary care provider who worked with me on the grant. And this is her dad up in Alaska. And she said, it took a little while, clinics and providers are adapting to this new way of doing things. Many patients and providers actually prefer it. Some of the providers like part-time being home, maybe being home with their kids or not having to commute so far. Many patients find it convenient. I have had a mix of patients that are appropriate for this and not. Some folks, they're on a break at work or their lunch break. They appreciate that I can call them and do their appointment over the phone rather than them having to come all the way down to the clinic and get all the way back. I have some patients that it doesn't work so hot for. I've got some patients who have schizophrenia, and working with them on the phone has been quite difficult. I've actually had them come and meet me in the back of the clinic, both masked, so that we could figure out how to best do this. It's been, again, sort of natural for some people, or it was a little difficult to get started, but then, people really became quite proficient in it. And again, we just have seen some really remarkable results, both with pediatric patients, adult patients, elders, really folks being able to adapt to this. Again, there are challenges, and there are many patients who do need to be seen in person or need to be seen in their home, but what an interesting time. So much we learned about. This is a way, again, to increase access to address the behavioral health situation that's going on. And so COVID, while it was a horrible thing, there's some silver linings in it in terms of how medicine and behavioral health in particular really got used to using behavioral health. And I'd be really curious in the chat box what people did. What did you do during COVID about behavioral health? Did you put your clinicians remote? Did you change up your exam rooms so people could sit 6 feet apart? What did you guys do? Did you take temperatures at the door if they came in to see behavioral health? Or did we had whole behavioral health departments working completely remotely from home for good chunks of the pandemic, and some of them still are and haven't come back into the clinic yet. So I'd be curious if folks could just tell us a little bit in the chat box, what did you do about behavioral health and how did you really address the virtual, and did it help? My no-show rate for my psychiatry clinic is almost to zero because I can reach people. Before, my no-show rate, maybe 30% of my patients didn't show up and I'm just sitting there, waiting and don't have a lot to do. Well, now my time is absolutely used to the max. And that double and triple booking we were doing, it's really got me hopping the entire day that I'm there. So it really did change up the dynamic in terms of behavioral health. The other thing that behavioral health providers do in our clinics is many of them actually help address physical health concerns. And I'm guessing some of you that are already doing this, it can be really helpful. So if someone's not adhering to their medication or their diet, or they're really struggling, or they got a new diagnosis, or even a diagnosis of cancer or something, or diagnosis of diabetes, any health behavior change, we're experts in behavioral health. We can also help with health behavior change because it's just a behavioral health thing, right? To really stick to a diet or an exercise regimen or do things. We can help people with stress, with grief. We've had behavioral health people step in and help the PCP if a patient needs some guidance on smoking cessation or difficult decision making. We can really provide education. And again, that referral, getting people to the right place, engaging them. If you have a behavioral health person comes into a primary care exam room, talks to a patient about what's happening with their mental health. Their PHQ-9 score was high. The person may be reluctant to go to behavioral health, or may just be addressing barriers to that. To have a behavioral health person in your clinic who can walk in to that exam room, talk to the patient about their behavioral health stuff, that person is more likely to reduce my no-show rate for those initial evaluations, because the behavioral health person, primary care person says, yeah, I really want you to go to behavioral health. Now behavioral health person says, yep, I have a colleague over there. She's excellent. I think you're really going to like her. Let's get you set up with her. I will track and follow and talk to you about any barriers you have. And that can just be really, really cool in terms of, supporting the patients while they're in the clinic. So lots of other good reasons to have behavioral health folks who are there. They can do more. You don't want to just use your behavioral health person for crisis. Like anyone that's suicidal, we're going to call our behavioral health person. You really want to use them for a variety of things going on. And I'm not seeing anything in the chat box yet about how you guys kind of used any virtual care, kind of what that looked like for your behavioral health clinics. But I would be just really, really interested in hearing, how that went for you, what that looked like, what barriers you had, what successes you had, because I really think the virtual option can be extremely helpful in the work that we're doing. The other thing, so we had this behavioral health provider, again, licensed or unlicensed, in the clinic helping out. The other issue that we see is we don't have access to psychiatric time, and we don't have it in tribal clinics. We don't have it outside of tribal clinics. This is a national issue, but it can become quite a concern and issue for many of our clinics, especially the more remote ones. And many folks have set up telepsychiatry, where they have that sort of access over the screen for patients. Many times the patients actually have to come into your clinic because they don't have data or minutes on their cell phone, or don't even have a smartphone in order to use, or live in a remote place where they don't have cell phone coverage. So one of the things we've been really trying to think about is, how do you use the psychiatrist differently? Rather than them just seeing patients one by one by one, what are all those different ways that your psychiatric team can help, again, move some of that common, less complex behavioral health into the primary care clinic and be extremely successful with it. We don't want to provide substandard care. We want to provide an excellent standard of care. So what are the things your psychiatrist could do? Well, your psychiatrist can do educational seminars for your primary care providers. We can do lunch and learn. We can come talk about depression or anxiety or trauma, substance use. We can come talk about things and train your primary care staff to feel a little bit more comfortable. we can do consultation. So we can have times when the PCP calls us and needs a recommendation saying, hey, I've got a person here. They've had depression in the past. They're depressed again now. I'm not sure what medication to start. Can you help me figure out what I should do? Or I have a person here, they have depression. I'm wondering if it might be bipolar depression. How do I know the difference? Can you help me? So having those kind of consults available, curbside consults or single consults available can be extremely helpful. And using your psychiatrist to see a person, come up with a treatment plan, and then turn that treatment plan back over to primary care to implement can save my time, save your psychiatrist's time to treat the person with schizophrenia or bipolar disorder or complex illness or treatment-resistant depression. It ends up saving your psychiatrist's time for the more complex patient, but I can pick up the phone and do a curbside consultation in 3 to 5 minutes. They're very quick, help that primary care provider and keep a person with a more common, less complex condition from having to even be referred to psychiatry. Many of you have 3, 6, 12-month waiting list to see psychiatry, or you don't have any psychiatry at all. And your PCPs are trying the best they can. They're working with their pharmacists, doing the best they can to do this work. But if we don't, have any effective treatment, then people are going to end up suicidal, maybe in the hospital, maybe having a suicide attempt or having a completed suicide, because it can be just quite tragic what can happen if people don't get the care. So for the psychiatrist to be able to consult and then save their time for more complex patients is extremely valuable. There are psychiatry access lines. In particular, many of you may be in states that have child psychiatry access lines. There are a bunch of HRSA grants across the country really helping states stand up these models. You can have your psychiatrist do chart reviews and make recommendations. Is the primary care provider on track in terms of patients getting better, being on the right treatment, and again, measuring their symptoms, repeating that PHQ-9 once a month, that GAD-7 once a month, making sure they're getting better. There's now the opportunity to send a consult to an outside psychiatrist who typically within a day will send the answer back. We're seeing this across the country, but it can also happen in your clinics. It's called either e-consult, or there are other ways to do it. You can actually even send a video to a psychiatrist, social worker, someone interviewing a patient, primary care interviewing a patient about their symptoms, send it to a psychiatrist who takes a look at it and makes recommendations based on that. We're just getting really, really creative and innovative in terms of how to use the psychiatric time for those less complex conditions, and then see me in person or by telepsychiatry if it's more complex. The other thing is to really think about when a person is better. Oftentimes, referral to a psychiatrist is a one-way street. They come to me, I treat them, they get stable, and then they stay with me forever. Really think about who are the patients on your psychiatrist patient list, caseload, that could actually be referred back to primary care for simple refills. Again, opens up appointments for your psychiatrist so that they're not seeing everybody, and that people that are stable, and this happens in the rest of medicine. If someone goes to see a cardiologist because they have a heart condition, once they're stable and they just need refills on their meds, they don't have to keep going back to the cardiologist. They go to the primary care provider to get their meds refilled. So again, in all of your clinics, if you want to increase access to psychiatric time, here's just a number of ways for you to consider to do that. What we end up with if we do this is the psychiatric providers can actually just help support a team. This could be a PCP in their caseload. This could be a hallway. This could be clinic A, clinic B, clinic C, whatever that looks like. Your psychiatrist is providing some of their time as direct patient care, and then some of their time is consultation. So it can be really cool how this works out, and you now have more access. Are all their services, all these consultations billable? No. You're not going to get your all-inclusive rate for some of the consultation, but what you are going to get is increased access and decreased suffering for your tribal members. Now, the other thing that I want to make sure that we cover, and this has been important in our grantees, is really looking at how do we combine primary care, behavioral health, and these traditional practices. As many of you know, they can actually be quite protective in terms of helping us with not, with things not progressing to full behavioral health diagnosable conditions, but also if someone has a diagnosable condition and they've lost touch with their culture or have not been as involved, or COVID has really, put a stop to powwows and other things that, thank goodness, we're actually starting to see a return of. But how do we really think about culturally, what this might look like? And this is a slide that was made by one of the members of our, we call it BH2I, is the grant process. And she, was really thinking about with her tribal nation, what does this look like in terms of some of the things that they did? But, the things that are really protective, really those connections to family and community. Again, that's one of the pieces that was lost. There can be cultural and religious beliefs. We need to make sure that we're not, putting everybody in the same basket. There are ceremonies and traditions that are important. Social supports, what's kind of, we kind of think about what are those dependable things in our lives. But, truly this sense of belonging and interconnectedness is something we can certainly see in quite a bit of our work. So we don't, really want to I don't want to just focus on primary care and behavioral health or general medicine and behavioral health. We really want to think about three-way integration. So if you're in a primary care clinic and a patient comes in with depression, and what seems like might be best for them could be a combination, maybe do some counseling, and they, we think about referral or what we can do to, cultural practices, what may they have not been involved in or want to be involved in, but really kind of thinking with that third lens about three different kinds of approaches and three different places where the person can get care. And again, keeping this in mind, and we are, extending the realm of the behavioral health treatment field. We've got more individuals, more people involved in care. And again, if we can get a larger behavioral health workforce, if we think about this in a larger way, it will certainly help us, with thinking about how we're going to address the high need and how we're going to address just anything new that's happened as a result of COVID. I'm going to wrap up a little bit. We had a lot of fun during our grant process with pointing our grantees towards different things that were happening and learning from them about what they were doing in terms of helping people continue traditions, stay connected. And the photo on the right is, for those of you who either participated in or know about the virtual powwows on Facebook, there's this great Facebook page, and people would dress. We had kids, adults, elders, all kinds of folks putting on their just, beautiful outfits, and having someone record or even holding the phone up, recording themselves and then posting these on Facebook. And this became just a real explosion of sharing what people were doing during COVID when they weren't able to go and do. And I just thought this was just so impressive. Little kids dancing, really getting this stuff recorded and posting on, having these virtual powwows was pretty amazing. And the website's still there and going on if you haven't seen it. But what do these support groups look like? We had a clinic that was giving out bundles of sage. We had, their drum groups and singing and regalia making, all these different things people were doing remotely, sharing on the screen, trying to really continue the traditional practices, which can be, again, protective and healing, as you're kind of going through a journey with behavioral health conditions. And there was COVID brought out the best in people, and people being creative and doing some of the things. And here's just some more screenshots from different things that folks were able to do and really keep going. Maybe some of these folks are on our calls today, but I really liked, leaving Cedar on, elders were so isolated during COVID, but leaving Cedar on their porches and leaving food and different things on the porches of elders. And here's just a woman doing artwork. And again, you can follow her and watch her be on video and do this. Here's some beading going on. Here's a language course. And then the storytelling. Again, so many interesting and creative ways to really think about the protective and healing issues with culture and with behavioral health, but also, with COVID. And what's happened is, how many of these might we continue? How many of these were very helpful during COVID? And maybe we connected with people we weren't able to connect with before. They didn't have transportation to get into certain events and things that were going on. We might actually continue some of these, and they could be, again, extremely helpful in really having more behavioral health services now post-COVID. It's going to be really interesting to see how much of this keeps going, how much of the virtual powwow keeps going, and people posting and doing from their homes either between powwow season or because they don't get to go. It's going to be just, I think, interesting to see how much of this continues as we get into now a little bit more of our post-COVID world. Some of the things we've just talked about are really this using technology, and this is just a reminder of all the different things. I don't know if any of you are in your clinics, and if folks are, I'd love to hear. Involved in Project ECHO. It started out of the University of New Mexico, and is really a way to help primary care and behavioral health, but to really help provide education and mentoring in your remote communities. I was the only psychiatrist in the remote part of the Navajo Nation. I worked out there by myself, and I really having colleagues and people that I could talk to was important. I would drive all the way to Window Rock, and we'd all get together and meet. But to really have had this remote mentoring and educational project would have been wonderful. A lot of these are actually helping primary care. You can have a Project ECHO for depression or anxiety. A particular Indian Health Service branch could say, we're going to do a Project ECHO. And some of you may already be doing this. I know there's one going on in Billings, Montana. I know that there's out of Albuquerque, out of UNM, you can actually hook into their substance use and behavioral health echoes and do them for free. But there are a number of these across the country, and many folks have actually used these to help get their staff, help them not feel so isolated. So we can say, hey, come on out here and work. We've got a community you can be a part of, whether they're here in the clinic or not. But also just helping primary care be able to treat people, to beef up the skills that they may not have, so that they're comfortable treating more behavioral health. And again, there's all kinds of patient-facing technology. Again, a lot of folks may not have minutes or data or cell phones, but many of our patients do. A lot of folks have used apps like Headspace for relaxation and stress. Some people are doing online therapies as a way to, if you don't have enough therapists in your clinic, how can we think about online therapies? And it's fine. The patients can come to the clinic and get online and, be in the videos. If you don't have enough staff, how can we actually do some of this online? So the patient doesn't have to be in their house where they may not have this access. They could actually be in the clinic, having access to some of the technologies in terms of, for the psychiatrist in particular, the patients come to the clinic, a remote clinic, and they see the psychiatrist in another clinic. That's how we've been doing that work for years. There's been a movement into doing some of this in the home. We have to really think about, when we do things in the home, what's the privacy level for the patient, what's going on in the background. I've had patients who during their appointment time, they were putting gas in their car, or were in the grocery store, or were just in places where it was noisy and a little hard to concentrate, but also I didn't think very private. So we really need to think about, with technology, how do we prepare the patient for the virtual visit, and how do we prepare ourselves? We need to be up and out of bed and off the couch too, and have our camera set correctly, and have our technology, and not have my cat walking over my keyboard, or you try as best you can not to have the dog barking outside, but sometimes that's a struggle. But we're using a lot of technology to expand access, and we're using it in our tribal clinics, and it's working for those that it's appropriate for. So I think we just need to be, again, COVID shook some of our assumptions about what we could and couldn't do. And now it's just a wide open field in terms of us really thinking about, how do we get more behavioral health care out to our members, using technology, because having more, everyone wants more. I want more social workers, more psychologists, more behavioral health people, more psychiatric time. Time has told us we're really not going to build a bigger workforce. A certain percentage of people want to be therapists. A certain percentage of people want to be psychiatrists. We have more need than we have workforce. So how do we use a different workforce and technology to meet the need? How do we do that? What does that look like for us moving forward? Now, I think we are about done. Yes, so this is kind of a last slide, then we're going to have some time for discussion. There are 2 videos, if you guys are interested. There's 2 links here, and it really can give you a sense of what it looks like when you begin expanding your behavioral health program outside of your behavioral health clinic and into primary care and other places. So there's one of Kodiak and their clinic and one from Chickasaw. And I really encourage you, take a look at this, because if you're going, how do they do this? Where do you sit? What do you do? What's it like in the exam room? What kind of patients do you see? These are 2 really nice videos of what that might look like if you are doing an integrated care project. So I'm going to stop sharing my screen so that I can see all of you guys. It looks like we got a really nice crowd here. We have some time for questions or comments, or again, sharing your experiences, because I have a feeling a lot of smart people on this phone call have figured out some ways to address behavioral health, have to expand that, have done some cool things during COVID. I don't know if folks want to put comments in the chat box, or we can also, you can just unmute yourself and ask a question, or just tell us about something that you're doing. So we have one comment here about doing child behavioral health. Courtney, we're going to share the slides. Someone wants the link for the slide for the, we can either put the link in the chat box or we can send out the slides. Which one are you going to do, Courtney?
We will be sending out the slides. It may take us a day or so to get all the slides sent out from all the presentations, but we're going to send those out. And the recordings will also be posted on our webpage.
Yes, yes, thank you. And we can also, Courtney, I don't know if you can cut and paste those links really quickly into the chat box. We may have enough time too to also do that, but be careful if you click on them, because it may start playing while you're listening to us. So we have this one comment about doing child behavioral health. This was a tricky time, right? It really was difficult to get started. Lots of people in the family talking, lots of background. Although I will say for some of the child therapists, it was kind of neat to actually get a peek into the patient's home, actually see what's going on there, who's there, what's, kind of what's happening. And I just love the last sentence here. The team had to become very creative. How do you do play therapy remotely? How do you really do this work? And it was a struggle. So everyone started out, almost overnight, they shut the clinics down, right? And then we were struggling. It took about everyone a couple of weeks to get Zoom or DoxyMe or whatever it is they used. And then we just started trying to do these, and we ran into all kinds of problems, people being prepared, all the noise and chaos in the background. And then over the course of the year, and that's kind of what I'm hearing from this comment in the chat box, is you had to get creative. You had to really think it through. You had to educate patients. We got resources started coming out. There's a one-pager for providers. How do you prepare yourself for a televisit? And then also for patients. You can send this to them and say, hey, quiet place, door shut, privacy. And there were sometimes people with, you're in the home with someone who may be abusive to you. How do you have a private conversation in a time when something like that's going on? So we had all kinds of things that we had to learn. And I'm, absolutely imagine doing your child therapy, trying to do it over an internet or even a telephone connection. Some of this just wasn't possible. We had to wait till the clinics opened back up. And then, everything touched has to be cleaned. It just becomes quite the issue. So absolutely, many things were a struggle, and many things we figured out we just couldn't quite do. We shared the links for the 2 videos. You guys can cut and paste those out into your browser and have those if you want. They're just lovely to look at. We've got more, but I thought those 2 are my favorite. Many of our grantees actually made a video so they could share it with their community and say, hey guys, thanks for supporting us in this grant. This was actually pretty cool. Other thoughts or questions that people have? Thank you, Simone. Really appreciate your comment. Other thoughts or questions? Was this helpful to people? What about, does anyone, in the few minutes we have left, one idea you will take away from today that you might use in your clinic to deal with the behavioral health issues? Anybody, just in the chat box, what's one thing you heard today? And I'm gonna take this and see what I can do, talk to my clinic. What would that look like? Just one thing. Someone had their hand up. I think I lost them. I'm always trying to watch for the hand raising, which I find is really cool. What's one thing that you guys heard today? You're like, this is something I might try, or this is something I'm doing. Yep. Getting that mental health counseling. Would you do any of it, Justice, by remotely, by televideo, by phone? You can unmute yourself if you want. Anything you might, a different way you might do it, telehealth, absolutely. And boy, have we done a year's worth of that, 1.5 years at this point. We're almost at the half year. We've absolutely done quite a bit of that. And again, for the right patient, right time.
Hi, Lori. I'm the one that had my hand raised up.
Oh, hello.
I've been on enough Zoom calls to know how to put my hand back down. But I just wanted, no questions, but just to comment on your presentation. I really did appreciate a lot of the evidence-based information that was shared. And I think from here on out to actually present the validity of, what the initiative that you're trying to push, evidence is basically the vital key, or plays a vital importance of how that actually has a, we can look at the comparative analyses of what's been presented and what's been not, successful versus what's successful. So I really do appreciate that a lot. In addition to that, I think that we can all, a lot of individuals on the call can probably attest to the fact that across tribal nations, we can always agree to the fact that we have a total lack of infrastructure. We don't have enough resources to actually support telehealth or teleclinic or telemedicine. And that's really sad, because we have really remote areas on tribal nations that individuals can't even access that luxury, the telemedicine, teleclinic, and a lot of it's really hurting our tribal nations. But I really do appreciate how you highlighted the fact, I'm on the Navajo Nation, so I really like how you highlighted that 1 hour commute for you to actually provide that teleclinic for behavioral health for individuals. And that really does, I do commend you and your team on that, because, having to travel that hour just to get telemedicine or telebehavioral health clinics completed really does show a passion for your work that you've done. I really do appreciate it and commend your team on that, as well as commend you on your presentation. I very much enjoyed it. Thank you very much for sharing that. And I just wanted to make sure that I was able to bring that to everyone's awareness, that just that total lack of infrastructure really does hurt the tribal nations and the clinic and health facilities alike, because if they can't get their objectives completed by way of not being able to connect with individuals and or clients, then we're basically hurting one another in that aspect. But being that you're having to be creative is another thing over Zoom platform or, electronic platform of interacting with clients is really hard. Getting them engaged, and there's not really, it to me kind of lacks the sincerity of being one-on-one. It's not, you have to build the rapport all over again with them, and then to help to build that trust even more so again. So thank you again very much for sharing.
Yeah, I think we're at our time. Courtney, do you need to wrap up?
Yes, I want to thank everyone for joining us this morning. Just a reminder, the next session will start in 30 minutes. So you do have a little bit of a break in between this session and the next one. Also a reminder to please make sure you sign out using the link either that I provided in the chat box or the one you received in the email. That way you can receive your CE credits for attending the sessions. You will also receive a link to the evaluation once you complete the sign out, we do ask that you complete the evaluation, just so we can know how the sessions are, were they meaningful for you, and we can use that information as we plan future webinars. So I want to thank everyone again for joining us. If you have any questions after we log out, please feel free to email me, and I will get back to you as soon as I can. Thank you.
And my email is also on the last slide if anyone wants to have any follow-up questions.
For everyone who is in this room waiting for the next session, which is the American Indian Alaska Native Suicide Prevention Hotline 988, I'm going to put all of you in the waiting room until our presenter arrives.